Let's bring in our guest into the studio, who is one of those woke women. This is Dr. Esther Njoroge Muriithi. She is a doctor. She's the Vice President and Regional Director for Africa, Smile Train. Dr. Ari, good morning.
Good morning, Eric.
Thank you very much for joining us. Happy International Women's Day.
Thank you.
Yes, you hear that proverb? What do you make of that?
I think the world should be shaking right now.
Not just mountains.
Not just mountains, the world.
Sleeping women are awoke.
Yes.
Okay. So we're going to have a conversation about our health, our rights, looking at universal health coverage. You're looking at who needs to do what, looking at where we are as a journey. But before we do that, tell us about this organization that you represent, Smile Train. What's that?
Well, it's definitely not a train. Smile Train is a global charity that is focused on children's health, specifically children's surgery, and very specific treatment of cleft lip and palate. And we build local capacity to ensure that children who are born with a gap on their lip or a hole in the roof of their mouth have access to timely, safe, and quality surgery. And not just surgery, but the other treatment that they need, speech therapy, rehabilitation, and orthodontics, nutritional support, that they can be productive members of society. And we do that by partnering with local hospitals, provide them with funding, with capacity building, as I said, and with every other resource that they need. So that when a child is born in Kenya, they don't have to wait for somebody to come from out there to come treat them. There are people right here who are treating them.
And why does it have to be right now? Because that's what we see, that a lot of a lot of these operations have to be done with funding from outside. Why is it that we have to be at that place where we can't have that local support that is needed for these children? Because just looking at the statistics, there's quite a lot of these children who suffer this condition. Why is it that we can't take care of it locally?
Many reasons, and I think that's part of why we're having this conversation. That cleft lip and palate is one of those congenital, actually it's the second most common congenital malformation, that if a child is likely to have something go wrong, cleft is one of those that is likely to go wrong. However, in our national programming, in our prioritization of healthcare, it's not one of those priorities. And therefore, there is no allocation of budget, there is no allocation of finances to take care of this conditions, and not just cleft, many other conditions that are supported by development partners. And so you find people coming in to plug in that gap, because children will still need that care. You cannot leave them behind. However, we hope and we keep advocating that our governments will pick all these issues up, and we will not need external funding for it.
What causes this?
The cause is not known. It's a multifactorial interplay between the environment and genetics. And for the largest percentage, you cannot pinpoint why a cleft happened. But there are risk factors that if any of those exposures a mother encounters them either before pregnancy or during the early age stages of pregnancy, before 3 months, then the likelihood of a cleft is much higher. And some of those are the nutritional status of the mother, where they lack some micronutrients, including vitamin B12, folate, folic acid, and exposure to toxins in the environment, smoking, taking alcohol while pregnant in the early stages. However, and I will repeat this because those risk factors end up being what the mother is blamed for when a child is born with a cleft. There is no known cause. So a mother could do everything right, but the child still develops a cleft.
So in short, there's no known preventative measure that you can take.
No known preventative measure.
At best, you can approximate it.
You can approximate it. You can provide fortification in food with folic acid. You can provide the supplements when the mother, before they even get pregnant, not even during early pregnancy, to prevent approximating. But you cannot say for a fact we will prevent it.
Has research shown any communities that perhaps have a greater prevalence of such occurrences than others?
Yes, it has.
Yes.
As I said, there's an interplay with genetics. And therefore, in communities where you have close marriages of close relatives, that interplay with genetics, you have a higher prevalence of clefting. Because we say a cleft is like an interrupted phone call. The way the mouth forms is 3 actually parts of the body that are moving towards each other so that they can fuse and form the complete lip. So if that movement is interrupted for whatever reason, then a cleft forms. And so in families where the genetics are so close, the likelihood of something going awry are much higher. And so we see higher prevalence of that. And then there's also the environmental things. So when in communities that live close to mines, for example, where they're exposed to those toxins in the environment, you have a higher prevalence of clefting.
I'm hearing you say all these things, and of course UHC is in my mind now, front and center, because we think UHC, and initially the thoughts from many Kenyans was that, all right, we're going to get healthcare that the government essentially will pay for. But I mean, the realization quickly has then been that it should be affordable healthcare across the country, that you should be able to walk into a facility, somebody should be able to meet your need medically, and you should then be able to pay for it. Should meaning it should be affordable to you. So I hear all these things that you're talking about now: preventative care, the care that you need should you be sick, and then aftercare. All factors of UHC that should be able to provide this information to these groups of people who may be at a higher risk of getting these conditions, for example, and not only just treating the condition, but talking to these groups about how they can avoid, if possible, or then live with the condition a little bit better. Do you see that UHC should be able to encompass all of these elements towards healthcare for Kenyans?
Absolutely, it should be. So treatment, for many of us, as you've rightly put it, health for us is a treatment aspect, which is the smallest portion, in my opinion, of healthcare. Because health is not in the hospitals. Actually, by the time you're getting to the hospital, you have, not you as an individual, but you, the society, has neglected your healthcare to the extent that it has gone crazy and caused disease. And therefore, there is a lot of health at the household level and at the community level, which is the prevention and the promotion of health. And universal health coverage, even if you read the literature out there, the highest benefit of the investments for the governments is at that level, at the community level, so that you prevent and promote health before it becomes very expensive. And the prevention and promotion of health is not a very expensive venture, because it is about continuously informing communities on simple interventions. How do you cook your food? How do you clean your water? Why do you need to go to the toilet and not throw it in the environment? What kind of foods are you supposed to be having? What crops do you grow so that they are complementing each other? Simple interventions that lead to major savings, because then you don't get the diseases that become very expensive. And so to answer you, yes, universal health coverage should be at that level where we are preventing before we come to treat.
So the conversation about universal health coverage, gained national limelight when the president put it among the big 4 of his administration this current 5 years. And then there was a launch, of course, of the pilot projects in the 4 counties, after which the president just said, okay, so now we're going to roll it out to the other counties. Haven't heard much about the actual implementation of UHC across the country. You are in those circles, so maybe you can actually just give us the leakage. Where are we as a country in terms of implementing and rolling out UHC?
I am a hangers-on. You know those guys who keep insisting on being in the class.
You must be there. This is which class? Biology? Okay, I'm also there.
I was there. Make sure you're in the picture.
Yeah, yes.
Literally.
Yes.
Just when the camera is about to click and just jump in. Anyway,
Yes.
I'm very passionate about health and healthcare, and especially the prevention of it. So, being a public health practitioner myself. So, yes, we did the pilot. And while there was a lot of report from the media that it was a failure, it was actually not a failure. Because the failure, in quote, is what informed the next step in terms of our road to UHC. Because it was a pilot to see if we provided all the services free, can we afford them, one? And two, what services should we be prioritizing? Because you can't cover everything. And from those learnings, the government has actually put together a policy, a UHC policy, which is basically the roadmap to how do we do it, what are we doing, who is doing it, and what are the resources that we need to be able to achieve it. So there is a policy, and I think at the moment there is, part of that policy is that the vulnerable households need to be identified so they can be protected from impoverishment as a result of out-of-pocket payments. So there is a process ongoing now to identify the vulnerable households and be able to register them. Let me stop there because I see.
You'll forgive my skepticism, but anytime I hear discussion tending towards a government policy in place, I begin to shake. Because there are very many government policies in place and nothing beyond it being in place has taken place.
Absolutely.
Now, when we talk about, for instance, vulnerable communities, the truth is our census pointed us out very clearly to who the vulnerable people in our society were. So it's not that we don't know them. We do know them. Now, the success or failure of the pilot scheme, what you said is absolutely true. Because really, if we were to look at it from a research perspective and said we were researching on it, there's nothing like it failed. All we saw was what can work, what cannot work. It's just information. And it is good that the policy is based on this. But if we look at wanting to actually implement the UHC, problems with the healthcare system are not a secret. We know what they are. The issues that need to be dealt with and which are a priority, specific to certain areas, we also know. Okay? Now, the question that comes to my mind is how do we finance this and ensure that we have the finances to ensure safe, what we may call service delivery? Because all this discussion, it seems like the government is buying time. Yes, buying time while it figures out where it's going to get money to finance this thing from. My view. Please, correct me if I'm wrong.
I would not purport to speak for the government,
No,
so
don't.
I would not know whether they are buying time. However, you're right. We know where our shoe pinches. We know where our challenges are, and the elephant in every room is, yes, we know how much it would cost to have the basic minimums, because that's what the policy sets, the minimums of what we would say are irreducible minimums. That if we were to say we actually have a UHC, then these are the specifics that we must provide to every citizen, not just to a specific few. But financing is the biggest problem for, not just for Kenya, but world over. Because our health is, at the end of the day, it's free to you and me, or it's at a cost that I can afford but somebody is subsidizing it. Somebody is providing the resources. And the resources are either coming from our government, which, as we have seen over the years from very many things we have signed, our government has signed. We have not attained those expectations from our taxes. And the second is from development partners, which is not sustainable, let's be honest. And therefore it goes back to, is our government committed to actually allocate resources from our taxes because it's our money.
I got to jump in and ask: is it because you've sat on several in several fora with the government when it comes to this and UHC? So to ask the question, where are we now? And really, is there the desire to make sure that we have this in the country? Even to look at things like the Abuja Declaration, where we were looking at 15% of every country who went and signed that pact, 15% going towards health and its research. And I think the best right now is 6. The best of everybody who went is doing 6-7%.
Yeah.
Do we see that kind of will then? Do we see it?
That's a difficult question to answer. Because for Kenya, the game changer, if I would say, for our country that has been different from every other year is a commitment from the highest office, which is a political will, which we have not had in a long time. Now, whether that political will translates to action on the ground is what remains to be seen. And action in the ground meaning, when our budget is read, will we have had increased financing towards healthcare? And then the other side of the coin is, we have a lot of leakages in the health system. Even if the 6% that is already financed, how much of it is wasted?
Right.
What are the efficiencies or inefficiencies in the health system that need to be addressed? If we look at NHIF and the kind of coverage that they offer, even though the UHC is currently anchored on NHIF, by the way, we will need to subscribe to NHIF to access it. What, let me say, how much is corruption affecting the financing that is already existing? So there's two ways of it. It's the increasing the funding, but also the plugging the holes that are leaking our resources. And because 2022 is next year,
We should forget it.
no, I would not say we should forget it. No,
We should just wait.
absolutely not. We remain optimistic, and we remain holding the government accountable and reminding them that you committed to it. You need to provide it to us because it's our right. It's our taxes. It's our money.
I think there's something that you're saying there, Dr. Muriithi, that political goodwill, we have seen some shift, right? So this time we have a government that has actually said big four, and we have said one of them is provision of universal health coverage.
Yes.
That is big. It's a big tick.
Very big.
If you even look back in the Kibaki years, when Charity Ngilu was the Minister for Health, and she tried to bring up a conversation about UHC, and she was just told, forget it. In fact, none other than the finance minister then, Muriithi, said, it's impossible. Just this dream of yours, just keep it first. We shall deal with it later. Right now, we have that political will in terms of making it a conversation. Is that will translating into anything further beyond that? So you say, yes, we now came up with a policy. After the policy, what next? How long should it take for us to actually see the results and the fruits of this renewed political will?
The results are being seen in different spaces. Remember, health is devolved for our country, which brings another spanner into the wheel, because while the national government will do the policies and be responsible for some of the health facilities, a lot of that, and especially what I talked about, the community level and the household level, comes back to the county. And we've seen some counties doing much better than others in terms of addressing the health needs of their populations. And again, I say 2022 being next year, this is a point of demand for the population. That yes, you ask for our vote for next year. What will you do for our health? How will you bring health closer to me? How will you increase my access? How will you reduce my expenditure? So the goodwill is translating as the conversation keeps being in the space, and as civil society keeps advocating for it, and as development partners keep pushing the government to honor that commitment. It is translating into action. It is behind the scenes. It's not in the fore, but it is translating into action. As to how long we will wait, hopefully before 2022, because that's a commitment from our government that by 2022 we should be having UHC.
No, the president clarified that what we're doing is just building the foundation blocks. So 2022, look for foundation. Don't expect to move into the house.
But before you break, the one point is that UHC is not a destination. It's a journey.
It's a journey.
It's a journey that we will possibly reach some destinations faster than others. We will never reach some, maybe, but it's a journey. But there has to be a starting point. And that's why the policy is about what are the minimums that must be provided to the communities.
So let's take a break at that point. We are discussing universal health coverage and the provision of universal health coverage. This time, discussing accountability for all. Who needs to do what? Who needs to be held accountable for? What role are they playing? We're having the conversation with Dr. Esther Njoroge Muriithi. She is the VP and Regional Director Africa for Smile Train, but she's also very, very passionate about the healthcare space and especially this matter of universal health coverage. Keep it right.
This is the Situation Room, the only way to start your day. Spice up your life.
Are they applying to these situations that we are saying? If they are, very bad.
I will answer your question with a personal story. In December last year, my daughter was home in the village with my dad, sorry. My mom is passed. And she stepped on a nail and she needed to have a tetanus shot. So I rush over and I'm going to take her for the tetanus shot, and we go to the nearest health center, which is a model health center. And model health center means that it should have everything that a health center should have. And we walk in there and we find mothers who are waiting for it. It's around 11 a.m. Mothers who are waiting for immunization. And when we finally find somebody who is in an office, it's the lab person who tells us, over here, we don't know, hatujui kama daktari atakuja. And I say, okay, what has happened? The nurses are on strike. And so if you really need this urgently, maybe you go somewhere else. And so we drove around looking for a private facility. We found one. We got the jab. But then my thoughts were still on the mothers who are on the queue.
Yep.
11 a.m. with their babies waiting for immunization. And it won't happen because the nurses will not come because they're on strike.
Yep.
And so to answer you, yes, there are glaring gaps in our health system. That you who is in the city may have access to many options, ranging from the private, if you can afford as high as you can afford, to the public, which is a health center in the community, perhaps, that is staffed maybe or has the supplies that the healthcare provider needs. But there are areas in Kenya where if you go to the health facility, it's just a building. The health workers are not there. And if they're there, they don't have the supplies that they need to provide you the care that you need. And therefore, the push for universal health coverage is not just to put it on paper that, yes, we have joined the other elite guys who are saying they have universal health coverage, but it is actually providing that access. That when I need that tetanus jab, I know I will walk into that hospital and I will get the treatment. It is being able to being able to catch cancer before it becomes a life and death situation. It is being able to have that mother deliver in a safe hospital close to their home, not drive many kilometers away. Well, in comparison to many African countries, and I mean many, Kenya is way ahead in terms of...
We are way ahead.
Yes,
yes.
we are.
Yeah.
Yes, we are. Yes. Believe you me, walk into Burundi and you shed tears. And I hope Burundians are not listening.
No, I hope they're listening.
If they are, they'll tell us.
But you
true.
see, the reason why you see me expressing this exclamation is that we shouldn't be judging our success
Based on
somebody else.
since failure or lack of success thereof, because then it puts us in a false comfortable position that we're okay, and yet we know we are far from being okay.
Absolutely.
That is really what I am trying to say. But even as you continue, let me ask you this question. When we talk of UHC, it sounds complicated, the things that need to be done. And yet from where I sit as a layman, the statement you made of us being way ahead comes true in this sense. Because of the NHIF, it's a tool which, in my opinion, if utilized well,
If utilized well.
yes, can actually provide this very same thing that we are saying, is so long as we're talking about starting with the basics, because there's no UHC system in the world that happened in a day, in a week. They happen over a period of time and in stages.
Yes.
So to start off with, we already have a tool that we know works. Why has this tool not been given the momentum that is required so that NHIF can actually be universal, starting with that? Because if it's universal, then anybody who has it has the assurance that there is some healthcare that is available to them. And with, in my opinion, with NHIF, this issue of how to ensure that those who are vulnerable are actually catered for, you have a tool that enables you to do precisely that.
Absolutely.
So why?
There is no why, because it is being utilized. The policy that is in place, the how is through NHIF. And as much as we'll disagree on the registration of the vulnerable households, the purpose of having that verified, biometrically verified data is so that those are the families that the government will cater for the NHIF subscription. And with that card, and you being attached to a healthcare facility, I have seen NHIF working. I have seen it pay the entire bill for my father when he was admitted in hospital. So it is there and it is working. However, there are two things that are lacking. One, the public knowledge of what NHIF can do is still very limited. And two, there is still a lot of abuses for NHIF. For example, if you need an MRI and you have private insurance, do you know that NHIF will first need to pay the first largest chunk before the private insurance pays the small portion? And because of that, the cost of one person is so large because they know the private insurance knows the loopholes to exploit. Those are some of the leakages that I was talking about that need to be plugged, the inefficiencies need to be streamlined, that the NHIF is catering for the large majority, that they are not bogged down with costs versus the collections are much lower. But there is also the other part of governance for NHIF, which is a discussion for another day.
So it would then seem as if there was a glossed over approach to this thing, whereby you see the problems that can actually be sorted, because some of the things that you're saying now doesn't need everybody to come around and sit in a conference or a seminar and say, yes, we are giving our approval and our backing to this thing. It seems to me that there's nitty-gritty that can be done in the background that can get this thing rolling. Because otherwise, then I think we run the risk of sitting in a position where we constantly talking about our commitment and we're ready to do this and we're ready to do, and it'll be another year where in 2021 there'll be another commitment, and
in
2023 there'll be yet another commitment, and we're just going round and round in circles, and we still have mothers lining up for hours waiting for a basic immunization for their child.
Yeah.
So I mean, what
and
are we doing?
I will go back to my statement that Kenya is way ahead, because that political declaration, first, it was unprecedented because it's the first time that the UN held a meeting that was specific about universal health coverage. And that is creating a commitment that globally they can hold each other accountable, which is the highest level of political commitment. So that was necessary. And the lobbying that went around it meant that a lot of people, including civil society, were involved in contributing to what should they commit to, what is a statement that countries are committing to. And that creates a framework that the UN together as a body can hold countries accountable to where are you? Hey, Kenya, you committed that by 2030 you'll have UHC. So where are you on that journey? That accountability is very key. But things are already moving because Kenya has had a form of coverage in one form or another ever since independence. And that's why I keep saying we are way ahead of many other countries. And I know we should not compare ourselves with other people's failure. We should be aiming at the level of UK and the other countries. But we still have to have a yardstick that encourages the journey as we are pushing forward.
Point well made. But what I keep wondering is, if you look at the NIH coverage in Kenya, it's not even 20%. Okay? something like 15.8. Now, if it's 15.8%, why are we making this process of ensuring that people get registered for NHIF so difficult? We got Huduma number the other day.
What has it done for us?
No, it's not what it has done. I can understand the logic behind Huduma number. I'll give you as an example of when a government decides that there's something that they want to do and they want to bring people together to do it, it will happen.
And they can collect information
Yes,
and then use
exactly.
this information for a particular goal.
Yeah.
It can be done.
Something that is as beneficial as the NHIF, even before you actualize it, what stops the process of simply registering people so that you know our people are registered? Then the other things that you're talking about then come into play. 15%, 16%. It's a dismal number.
Very.
So even as we talk about, in fact, I would even rather stop this conversation of UHC right now because that percentage is too small.
And I will tell you why it's too small. NHIF, the way it has been structured, is a players club.
Yep.
So if you don't pay, you don't play. And for it to address the needs for, like what you're saying, everybody is registered. It needs to be re-engineered, restructured, so that there is room for that massive registration and who pays for the non-payers to play.
Which is more difficult, this thing that you've just described, than this convoluted, lengthy process the government keeps talking about? Okay?
Which one?
Which one is simpler? What I'm asking is, yes, pay as you play and as you keep playing, as the eminent doctor has just mentioned. Which is more difficult? To actually simply register people. I'm a registered voter, but I don't vote every day. Okay? Okay? I may be registered with NHIF, I don't fall sick every day.
But at the time that you need to, you will.
Yes, and the issue of
have it.
payment also. If you really explain the importance of this thing and you show people ways in which they can actually pay. Look, I'm not going to pretend to be an expert in these things. But what I do know is if there is a will to ensure that people get that coverage so that even when you talk about payments for that particular service, okay, you structure it so that some people may end up paying a little more than others, but to add to that pool so that everybody is able to enjoy the service. All right, then the government can come in and pay for whoever else they want to pay for. Yes.
Dr. If I can just jump onto that just a little bit, maybe we can stop me where I'm wrong. But if we're looking at these model UHC examples around the world, with the NHS in the UK, and then also the health system in the US, everybody is pre-registered. It's almost, I want to say, quote unquote mandatory, that as you're getting things like a social security card, your health aspect is accounted for there. Now, your taxes that you pay, it's all put in. It's all part of it. It's quantified there. So there's no question later as per, okay, this person doesn't have a card. NHIF does not necessarily cover this person because at whatever level you're paying taxes, that percentage is taken out and pays for your health. So there's never a question about, do we have enough? Are they under NHIF? If this person is then admitted in hospital, are we going to be able to cater for them? So from the very beginning, that's why it makes sense for me like that. We can't say that we're still looking for biometrics.
What I hear you saying, Ndo, I think
is that everybody be included in the system from the get-go.
But those are the lessons I think that you say they were picked out of the pilot in the 4 counties. Is it free, like, coming from the taxpayers' coffers, or is it going to be financed by people
So it's still a
separately?
question. It hasn't
Because if you
landed
do
yet.
that, if you say that, because you've paid tax, remember, we don't all pay tax at the same level. There are people who only pay tax at consumption. There are people who pay tax at income. So what tax is going to be factored in as the tax for NHIF?
So this
Is
is
it
my
like
thing.
a fuel tax?
You know,
is
Eric,
it a VAT? Is it
That's
an
perfectly
extra
understandable.
percent?
This is why I'm asking here. So where did this thing land? The questions were being asked in terms of, all right, are we going to be able to make it free? Do we need to have a surcharge for those who pay tax at consumption? So where did this thing land? Or is it still questions up in the air in terms of, all right, there was a pilot. So then?
But Eric, no, please, sorry. Go ahead. Go ahead, Doctor.
I think your arguments are very valid. And that's where we would want to see Kenya at. And it's not impossible, because we have seen other African countries be able to actualize that. And I'll give a good example. I know our dear CS of another ministry said we should not compare ourselves to a village. But Rwanda has had their people fully registered on their national health insurance, the Sante Michel, whatever it's called. And as of last year, 94% of the population was covered. Because, as you rightly put, the government deliberately said, we are going to do this, and they committed to doing it, and then tiered it such that if you are identified as, I don't know how they do it, but let me give examples of colors. If you're color coded red, when you go to the health facility, you don't pay anything. But if your color code is blue, then you pay 100 shillings.
Right.
If your color code is green, because it depends on your income
And it's
your
predetermined.
capability, it's predetermined.
Okay.
Which shifts around the time, because you could move from red to green
Yes.
Yeah.
as
Yes.
your fortunes improve.
Yeah.
And therefore, it boils back down to the commitment from our government, the will to actually do it and to actualize it. So it's not still questions in the air. For me, what I celebrate about having a policy is our government doesn't do anything unless there's a policy.
That is understandable and it is wonderful. Okay? Track record on operationalizing these policies, not good.
They are operationalized by other countries.
Not good. Yes, that is our history. Has the ministry brought to the fore proposals and propositions such as this one that the national government, so to speak, in its entirety have rejected? Why I'm asking this question is this. Eric mentioned taxes. We have a really efficient tax system.
Aggressive is the word.
Yes, but it's efficient.
Yes.
You
It works somehow.
The issue is not, I'm not discussing what happens to our money, but the system that is there to
collecting
collect
it.
taxes,
It's very
man, they
efficient.
collect it. Now,
Yes.
because it is that efficient, you tell me, you know who ought to pay what, even before they pay it. And you know what it amounts to. You already have a system in place that could be used to tier the issue of contributions to NHIF. This thing is not really that complicated. Every time something is complicated, it's because someone is making it complicated. All right? What I find more complex is why it is this confusion that we keep seeing in our ministry. It's like every department of our ministry, it's like they're independent. It's like the people who deal with this, it's their own thing.
Immunization people. Are
There's
immunization.
the immunization people.
Public health. Public
Yes.
health.
Maternal health care, maternal
Maternal
health
health
care.
care.
Now,
Water.
it's the same thing with the national government. So are we mirroring what happens in the national government with our ministries? Because until we got this so-called super team for COVID, all right? And even then when you talk to people, you talk to the healthcare workers, you talk to those in the county governments, it's like, yeah, it's there in theory, but but how it works, you know, there's you're given a list of things which there's this and there's the other and there's the other and there's the other. I'm putting forward this perspective. The government doesn't have any will whatsoever in actualizing the UHC. They have the will to talk about it, to discuss it, to give the impression they're doing something, but to do it, they don't.
I beg to differ, because I want to remain optimistic.
But that was a
Because-
statement of optimism. You didn't hear the optimism in my voice?
You are very optimistic.
Very
Yes.
optimistic that the government
The
has
government-
no will
That
whatsoever,
the government will do what I know it's going to do.
which is absolutely nothing.
Yes.
You know, somebody once told me that we keep re-engineering the same thing and calling it something different. So first was the primary healthcare movement, and then along came Abuja Declaration. Then now we have recoined it and called it universal health coverage, and it's possibly a gimmick to keep people in boardrooms in high levels and earning per diems or whatever else they do. And there's a tinge of truth to that. Okay, maybe a whole bucket of truth to that. But however, as Kenyans, as citizens, as civil society, as people who have the best for the citizenry at heart, it is our duty, it is our role to keep poking the government until they stop doing nothing.
Right.
And that is exactly what we are doing. Keep poking them until they stop doing nothing. If that policy is put and starts gathering dust, we are the ones who will have failed the Wanjiko out there. Because we are the ones who are in the know. We are the ones who know the benefits. We are the ones who know how it should be done, how simple it is to be done. Right. But yet, we did not push our government and our politicians to action.
Now, actually, when you talk about that accountability, for the citizens to be able to push this, then there needs to be a lot of sensitization of the citizens. Who takes up that role of sensitizing the citizens and saying, for example, next year, there's going to be an election. Health is devolved. Ask the person who wants to be your MCA, your governor, what are they going to do about health? Ask the person who wants to be a senator, what are they going to do to ensure that their county is well financed to be able to cover health? How do we make that conversation like a main conversation, a topical conversation in 2022?
That's a difficult question because politics have a way of clouding everything out and just making everything so noisy that you can't get your voice in. However, civil society, and I keep going back to civil society, which includes the non-governmental organizations, the citizen representative groups, the community-based organizations, and especially the community-based organizations, because they are at the community level. Given the right information, the right packages, the right tools, they have the power to change that perspective. However, we have continually seen the citizens prioritizing things like roads, which is what they can see, what they can touch, until a relative falls ill and they realize they can't access the healthcare that they need without selling their plot. That's when they realize, oh, our health system is shattered. So it's providing that information at the grassroots level, and as to who takes it up, there's a robust civil society in healthcare in Kenya, which has done a bit of strides towards that. There's still a lot that needs to be done in terms of educating the masses, and not just educating them about their rights, but educating them about their responsibilities. Because health is not about the government doing it for the people. It's
Do you
also
think it
about
helps to continually expose the areas where this is not working and put some pressure when you have it in the public glare to say that, look, this is not working. In this area in Kenya, in this county, this continues to be an issue. If those issues continually come out, do you think that kind of pressure on the powers that be, quote unquote, would work to say, all right, because my father used to say that if you want something done, you continue to nitpick at that thing until they either get irritated with you and are saying, okay, let's get rid of this. And how are we going to get rid of this problem? Fix it. So do you think that if these stories or if these issues are continually out in the open, that something will be done about it? So we don't ignore it and say it's bad, but bring it out and say, look, in Nyeri County, this continues to happen. In Kisumu County, this continues to be an issue. In Isiolo, this is an issue. If you continue to bring out those issues, do you think that it's either they get tired and do something about it, or make sure that it works?
It's possible. It's what needs to be done. Constantly be the pain in their back that eventually they have to turn around and do something. And the power of the media is being able to bring those issues to the fore in a constructive, responsible manner. And I say that because sometimes we bring issues in a way to
muddy the waters.
Thank you. But if our goal is to bring the issues to the fore so that action is taken, because health being devolved means there are things that the national government will say it's not our responsibility. And there has been that back and forth constantly, that the county government says, no, it's the national government. The national government, no, it's the county government. And eventually the person who suffers is the grass, which is the common.
Sure.
Yeah. So there is a lot of value in keeping on highlighting where it's not working, where the challenges are, and also proposing the solutions.
So there's going to be some discussion on this particular issue of universal health coverage. Just tell us about that as we conclude the conversation today.
Yes. So I think, in my opinion, it's the most important conference that anybody could ever attend about healthcare in Africa. It's called Africa Health Agenda International Conference, Uhc. And it's organized by AMREF Health Africa. It's running from today till Wednesday, every day from 2 p.m. to 7 p.m. And it is a very rich conversation from across all of Africa. So even as we are saying, who are we comparing ourselves to, we get to hear from other countries, what are they doing? And not just from other countries, from Kenya, but at the global level. What is being done? Who can we learn from? What steps do we need to be taking? So that conversation is happening in the next 3 days. And it's a thought-provoking conversation that as Kenyans, yes, we have made these steps, but what more remains to be done, and how do we need to get there? So you can attend. It's a virtual conference. So thankfully, any of us can attend from the comforts of our offices, our homes, and you can register at ahaic.org, ahaic.org, and get to hear what the global, regional, and local conversation is about universal health coverage.
What do you hope to happen after that conference? Just like you said, let's not just have people sitting in boardrooms and having conversations left, right, and center. So what happens after the conference?
What I hope to happen, because this is the first time that this conference is going to be virtual, which means there is opportunity for anybody to attend, because it's free. It's free attendance. What I hope to happen is that a lot more voices get to pick up the action, the call for improvement of healthcare in their localities, whether it's at your county level or at the Kenya level or at the Africa level. Because one of the challenges that we have in this move towards providing access to healthcare is a fragmentation.
Sure.
Because while I am making a lot of noise in my little space, somebody else is making a lot of noise in their little space, and we are not having a lot of that conversation converging to make a much louder noise. So picking up more people to advocate for health, because it's not... The fortunate thing is that healthcare affects each and every one of us. The lack of quality healthcare affects each and every one of us at some point.
For sure.
I want to be able to, when I'm having arthritis, to be able to access care in my health center, not having to go to wherever that I cannot afford.
Some expensive facility.
Yes.
Thank you very much. Dr. Esther Njoroge Muriithi is the VP and Regional Director for Africa at Smile Train. She's been having a conversation with us about universal health coverage, talking about accountability this time. Asante sana. Hope to have you again soon.
Thank you very much. Thank you for your time.
Thank you.
This is the Situation Room, the only way to start your day. Spice up your life.